Hello everyone, my name is Ramani and I'm an anaesthetist. So it is with a degree of self-interest that I've been giving a bit of thought to whether or not anaesthetists will be needed in 25 years. Why 25 years? Well, I'm giving this talk as part of the ARIES series to celebrate 25 years of the Royal College of Anaesthetists. But for me personally also 25 years is quite apposite. Because in this timeline of my career, which started in 1991 when I became a medical student, and is likely to end in 2042, when at the age of 67 or 68 I retire, that's a 50-year career or there or thereabouts, and I'm exactly halfway through it at the moment. So I kind of want to know what I'm going to be doing for the rest of my working life. So I'm going to draw a timeline for you because I think it's important to look backwards as well in order to be able to look forwards. From the beginnings of modern anaesthesia in 1772 through to giving some predictions for what we're all going to be up to in 2042. And modern day anaesthesia, that's a 270-year timeline, began, I guess, in 1772 with Joseph Priestley. Priestley discovered, amongst other things, nitrous oxide, nitric oxide, ammonia, and in fact oxygen. And one of his early experiments, he put mice in bell-shaped jars of nitrous oxide and noticed that they became less lively and ultimately died. He then, in 1774, started putting mice in bell-shaped jars of oxygen and found that they became livelier, but he was too busy discovering other gases to investigate this much further. So then in 1798, this chap came along, Humphrey Davy, and at the age of 20, he started looking into nitrous oxide again. And he studied it further because he was interested in the fact that everybody at that time believed that nitrous oxide was harmful, it was toxic, it would kill you. But actually he found it to be safe when administered for short periods of time. So he subsequently spent a lot of his career investigating the physical and chemical properties of nitrous oxide, or dephlogisticated nitrous air. And in his seminal work where he summarised all of his findings, he wrote towards the end, almost as a bit of a throwaway comment, that as nitrous oxide appears capable of destroying physical pain, it may probably be used with advantage in surgical operations in which no great effusion of blood takes place. Now, sadly, his thoughts didn't really make it into general healthcare practice. And so while the rich ladies and gents were using nitrous oxide to please themselves at parties, it didn't really take hold in healthcare until much, much later. So in 1846, this plaque is on Gower Street, down the road from University College London, and it marks the place where the first surgical anaesthetic in England was administered on the 19th of December 1846. Now, the surgeon for that procedure was Robert Liston. He was a vascular surgeon of Scottish origin. And this is a picture of Robert Liston in action, doing, as he often did, an amputation of a gangrenous leg. Now, hiding there in the corner is William Squire, and William Squire was the nephew of an apothecary called Peter Squire, who was a friend of the surgeon's, and he was a student at the time, and he administered the anaesthetic for the first time on the 19th of December 1846. And this is a picture of the apparatus that he used. This was actually rediscovered just a few years ago and is now in a museum that he used for administering the ether in those days. Now, he thankfully wrote up his experience, and I'm going to read directly from that. And I would ask you perhaps to look at this image and think about what it must have been like to sit in that operating theatre as I read this to you. The house surgeon then saw the patient carried in and properly placed, a handkerchief lightly covering his face. I had the ether apparatus on a small table brought close to the left side of the head and spoke to the patient. He knew my voice. As I raised the lower part of the handkerchief to bring the end of the tube into the mouth, directing him to draw his breath deeply. In no case since have I seen ether taken more easily and quietly. The respiration soon became deep and regular. His face was flushed instead of pale when the handkerchief was removed, and a folded cloth instead, enclosing the free end of the tube, covered the mouth and nose. When unconsciousness was complete, I remember no stertor. The apparatus was moved back a little and no more ether was given. No twitch or sign of pain was made by the patient as the operation began, and in 28 seconds the limb was off. A placid sleep continuing, the vessels were all tied, and wetted lint was placed between the flaps, which were brought together and lightly covered before consciousness returned. Then the patient, rousing as if from ordinary sleep, was heard to say, "Take me away. I can't have it off. I must die as I am," while murmurs of satisfaction passed around the theatre. When asked as to pain, he said it seemed more in the toes than the knee, and until he was raised to see for himself, could hardly believe the limb was gone. The expressive smile of surprise and delight with which he then looked around is deeply impressed upon my memory. So a few things spring to mind about that recollection. The first is the pain in the toe rather than the knee, which sounds to me like the beginnings of phantom limb pain, a type of neuropathic pain which afflicts people after they've had amputations, particularly if their pain relief prior to the amputation has been very poor. The expressive smile of surprise and delight, that's something that I, as an anaesthetist, have experienced many, many times when patients who were very anxious prior to their surgery wake up and realise that it's all done. But perhaps the most interesting thing for me as an anaesthetist was the no stertor, which is snoring. That to me means, was the patient breathing? And in fact, I wonder whether the thing that saved the patient on that first administration of ether was the fact that the amputation took only 28 seconds. Now, some of us as anaesthetists might dream of a surgeon taking off a limb in 28 seconds. But in fact, actually, I think the rest of Robert Liston's career may highlight the fact that speed is not necessarily always good, because this was not his most famous operation. He did another leg amputation when in his enthusiasm he took off the scrotum at the same time. And his most famous operation, he took off the limb, he sliced through the assistant's fingers and the assistant died of gangrene, the patient died of gangrene, and he slashed through the coattails of a distinguished observer in the audience and he died of fright. We'll move forward to 1890 and the Schimmelbusch mask, invented by Karl Schimmelbusch for the administration, again, of ether anesthesia. So a cloth is placed over this mask, which is placed over the patient's face and nose and mouth, and they inhale drops of ether that are passed on to that. And the idea is that the ether is not allowed to touch the patient because it's very corrosive. And the Schimmelbusch mask was used really up until the 1950s, and in fact it is still used in some parts of the developing world today. Moving forward to 1952, this is one of my great heroes of anaesthesia and critical care. This is Bjorn Ibsen, and he was a Danish intensivist. He was the father of intensive care medicine. So in 1952, the polio epidemic was afflicting Denmark as it was many other parts of Europe. And the treatment for respiratory failure, which is one of the consequences of polio because it gives you muscle paralysis, was to treat patients with ventilation using iron lung devices. So the patient is placed into the lung and negative pressure applied to draw out the lungs and therefore draw in oxygen or air. But Bjorn Ibsen noticed that this was not sufficient because these patients were dying of aspirating their secretions. They lost their ability to prevent things going down the wrong way into their lungs, and therefore they were drowning in their own secretions. So he decided that ventilation wasn't enough. He had to put a tube into the trachea, into the windpipe, in order to protect the airway. And then he got 200 medical students to work in shifts around the clock, manually ventilating those patients in order to keep them alive. So the mortality from that polio epidemic dropped from 90% down to 25% as a result of that single intervention. And that was the beginning of intensive care medicine. So where are we today? Well, anaesthetists fulfill a variety of roles. We are members of great teams, trauma teams, cardiac arrest teams. Some of us jump out of helicopters when there are accidents and out-of-hospital care is required. We look after patients on intensive care. We're great proceduralists. We're technically very dexterous. We look after patients with chronic pain. We look after people from birth to death. At the time that they are born, we look after their mothers. We give them analgesia in labour. And we look after people in every age in the operating theatre. And that, of course, is the role in which the anaesthetist is most known. So what is it that ties together all of these different things that anaesthetists do? So manual dexterity is certainly one of them, a great deal of technical precision. We are applied physiologists and pharmacologists. We understand how the human body works, both in health and disease. And we understand the pharmacology, how the drugs work in health and disease. But above all, I think we have to be great communicators, because we see people at possibly the worst times of their life, with the exception of childbirth. We see them when they're about to undergo surgery, which they usually don't want. They're super anxious, and we have to gain their trust in a very short period of time. We have to talk to people whose relatives are in intensive care, possibly at the end of their lives. So we have to be good communicators. Now, today, disease is changing. So these graphs that are about to follow depict cancer. So this is over the last 100 years or so, from 1930 until 2012, showing the rates of cancer over those years. And you can see that there was a big rise, and there's now a gradual falling off of cancer death rates in the United States in this case. People are dying less, thankfully, from cardiovascular disease. And that's partly as a result of a reduction in the incidence of cardiovascular disease, but it's also as a result of primary and secondary prevention therapies. So the way that we treat disease is also changing. So this is the rates of coronary artery bypass operations, which are the operations used to treat ischemic heart disease. And you can see that the rates are dropping, and that's out of proportion with the number of patients who have it, because we're better at treating patients without surgery. But we have different problems now. So the obesity epidemic is rising, and a whole bunch of comorbidities or other diseases that go alongside that. Now, in terms of anaesthesia, that is a great healthcare success story, because compared with the 300% mortality of Robert Liston's operation, we know that the intraoperative mortality, the on-table death rate for patients undergoing general anaesthesia in the United Kingdom, is a fraction of a percent. So if you undergo an anaesthetic, it is generally safe, with a couple of caveats. But there is a growing demand for surgery. So we estimate that 313 million operations per year are done worldwide, 10 million procedures per year in the UK, and that accounts for about 10 billion of the National Health Service budget in the United Kingdom. So there's a lot of work to do currently, but what will 2042, 25 years from now, look like? So I'm going to give you some predictions, and then we'll see what you think. So we joke sometimes in healthcare about Dr. Google, and we all know that access to the internet and access to very powerful search engines such as Google means that you can put in a list of symptoms or signs and come up with diagnoses as a result of that. I wonder whether medical students will be required to learn the great long lists of symptoms and signs and differential diagnoses for different complaints that we used to have to as undergraduates and even for postgraduate exams. Because why would we need to do that when we can get it all at the touch of a button? Initiatives such as Google DeepMind, which is it's an artificial intelligence company, and there are many, many others like it, are looking at the role of machine learning in healthcare. So can we use data for computers to auto-program to make predictions about how patients should be cared for? So big data and machine learning, I think, are going to be things of the future, which I think are going to replace the role of healthcare professionals. Personalised medicine is something that is just emerging now in both the public and the professional consciousness. And what this means is things like stem cell therapy and gene therapy. So can we not say this disease is going to be treated this way, but say this patient with this disease and this genetic profile will be treated this way? Because we know that the complexity of disease requires a more personalised approach than just saying one size fits all. What about the rest of society? This is a driverless car. They're already on the road. And I predict that in 25 years' time, driverless cars will be everywhere. Now, there are obvious implications of that for anaesthetists. So for a start, hopefully, that means that we will lose a lot of custom because driving will become much safer, and therefore there will be fewer road traffic accidents. But it does ask the question, if we can have a driverless car, can't we have a driverless anaesthetic or a driverless anaesthetic machine? And is it not true that despite the fact that anaesthesia is very, very, very safe, the reports such as these, the national audit projects of the Royal College of Anaesthetists, demonstrate time and time again that when rare catastrophic events occur, it is usually as a result of human factors. Not necessarily even human error, but humans not quite managing things as well as they would in other circumstances because of a variety of different reasons, psychological, social, and otherwise. So if you take the humans out of the system, maybe everything gets better. And people are starting to really look at this. So this was a paper published 3 years ago in the British Journal of Anaesthesia, which described the evaluation of a closed-loop total intravenous anaesthesia drug delivery system. And what that means is that you set the machine at the beginning, and it delivers a certain amount of anaesthetic to the patient, and without anybody else touching it, it maintains the depth of anaesthesia, so the degree of sleep, within certain parameters. And they found that it was better than humans at maintaining the depth of anaesthesia within predefined limits. And that now, there have been over 30 randomised trials testing this sort of technology against humans, and the overall summary of all of that is that the machines are better than humans. Now, anaesthesia and what we do in the operating theatre is about much more than just keeping people asleep. We are the applied physiologists. We have to deal with problems. We have to maintain the patient's blood pressure. We have to manage their fluids. We have to give them pain relief and a whole bunch of other things. And you may ask, we've had autopilot in aeroplanes for ages, but we still have pilots in aeroplanes. So does it not follow that you wouldn't have a driverless anaesthetic in the same way that you don't have a passenger aircraft without a pilot? And you're absolutely right. And I think there are two reasons why that is currently the case. The first is that the general public want humans in charge. So that's a given. But the second is that all of these clever algorithms can't deal currently with the rare and catastrophic event, like the birds flying into the engine, and Sully therefore having, through professionalism and skill, landing the aeroplane safely in the Hudson River. Now, for anaesthetists, the metaphorical equivalent of the flock of birds is, of course, the surgeon. But imagine a future where you don't even need the surgeon, because nanotechnology or nanobots are going to transform the way that we cure certain diseases. So nanobots, so nano-sized components which can be injected into people, can carry drugs and cure cancer, potentially. Very good early data about this. So you can imagine that a whole bunch of things that are currently treated by surgery, such as cancer, such as atherosclerosis, so heart disease and so on, might actually in the future be treated without the need to go under the knife. So what am I talking about here? I'm talking about man versus machine. And in 2016-17, I think it's pretty clear that man is better than machine. But in 2042, what are the options? Man plus machine better than man? Maybe. So man and machine working together better than man? Maybe. Will the machine be better than the man? Or will the machine be better than man and the machine? Okay, so currently we still have to put the dishwasher on. It doesn't do it itself. Currently, even though we have systems which can beat the world's best chess players, they can't take the dog for a walk. But all of these things may come to combine over time. That means that the machine may be better than the man and the machine, because you take the man and the human fallibility out of the equation, we may actually be better off. Now I can see you're going, this is nonsense. But actually, there is a theory that's been around for a long time, and it's called singularity, or technological singularity. And here it is. So we've got time and intelligence plotted against each other. And the blue line depicts human intelligence, and the red line depicts machine intelligence. And the machine intelligence started in the 1940s with Alan Turing. And we are about there today in 2016-17. Now, the point of technological singularity is where those lines cross, where the machines become more intelligent than the humans. Now, when is this predicted to happen? Because there are a lot of people very interested in this. So Ray Kurzweil, who is a leading proponent, international proponent, he gives great talks on this, reckons this is going to happen in 2045. There was something called a Singularity Summit, can you believe it, of experts who are interested in this theory. And they concluded that it would be in 2040. And I'm here to talk to you about what anaesthesia is going to look like in 2042. Makes me wonder whether actually all of this is a moot point. And if that is too much to take in a slide, I'm very grateful to Tim Urban and the guys at Wait But Why for allowing me to use their work to depict this concept much more simply. So this is time against human progress. We are there, standing there. If you're struggling to believe what I'm telling you, it could be that when you're standing there today, it actually looks like that. So last night, I heard a great talk by one of my PhD students who was talking about how to involve patients in research. And afterwards, with all of the PhD and higher degree students that work within the Surgical Outcomes Research Centre at UCH, the Bloomsbury Innovation Group, and the Health Services Research Centre based here at the College of Anaesthetists. Most of us went out to the pub because that's where all the real research and innovation happens. And I talked to them about the talk that I was giving today. And I said to them, will anaesthetists be required in 25 years' time? Because these guys are the future of anaesthesia, of course. So it's in their interests to think about this. And I was really interested in what they thought I was going to say. And a couple of them looked at me slightly nervously and they said, oh no, you're not going to stand in the Royal College of Anaesthetists on the Royal College of Anaesthetists' 25th birthday and say that anaesthetists won't be needed in 25 years. And I'm not saying that, because I think anaesthetists will be needed, but I think they will be for a combination of good and bad reasons. So I think we're going to see a change in what we do, an evolution in what anaesthetists do. I think a lot of the stuff that we do, which is technical, will be taken over by robots or other machines. Diagnostics will change completely for all of healthcare. Already there are big changes emerging in radiology, the interpretation of X-rays and CT scans, which is going to transform the way that that profession works. I think there are going to be aspects of what anaesthetists do which will continue to be a burden to society and to patients. So chronic pain is one of those. So currently today, 20% of the European population is afflicted with chronic pain. This has a huge cost to society. And yet less than 2% of these people attend a pain clinic, which are predominantly run by anaesthetists. Now, it may be that not many more than 2% need to attend a pain clinic, but it seems unlikely to me. So it may be that we need to see an expansion of some of these sorts of services. The second reason is that innovation takes time to embed. So this is Everett Rogers' diffusion of innovation theory in the 1960s first espoused, and it talks about how any innovation, there will be people that are the innovators and people who adopt very early, and then there will be a spread of people over the whole spectrum, including the laggards right at the end, that are always the last to take things up. So I think that's the same with any innovation, and how long that cycle takes is a matter of interest. So for example, smartphones haven't taken that long to embed, but other innovations take much, much longer, and I think it is all about how the public view the usefulness of these innovations. But a much more important problem is fear, because the fear of innovation is something that could hold things back. And this is important for healthcare professionals and for the public. We need to improve trust between professionals and public regarding access to data, because all of the machine learning stuff that I was talking about earlier requires data to go in. So the people that are socially disadvantaged, who generally don't take part in clinical research even today, if their data are not being used in clinical trials and in machine learning algorithms, they will become even more marginalised than they are now. We have a massive problem with global poverty. So nearly half of the world's population, 3 billion people, live in poverty. 2/3 of the world's population do not have access to safe surgery and anaesthesia. And we as anaesthetists have a social responsibility to educate and provide high quality healthcare, not just in Britain, not just in Europe, but globally. And finally, diseases are changing. So 1/3 of babies born in 2013 are expected to live to 100 years old. And those people will be in their 30s or late 20s in 2042. But treatments are changing. So when I was a medical student, you couldn't cure people with liver metastases, so with a spread of cancer to the liver. Now you just cut it out. And the technological advancement combined with an aging population with a lot of diseases means that we need to think very carefully about how we treat patients, because it's not always a question of whether we can, but also of whether we should. Because all treatments can have complications. And so while in surgery anaesthesia is safe, post-operative complications afflict a very substantial proportion of patients who undergo surgery. And even if surgery goes, one can imagine that the treatments that we offer patients will also have side effects. A lot is talked about personalised medicine, genotyping, stem cell therapy, all of that sort of thing. And that's all true. But for me, personalised medicine is also about much, much more than that. Personalising healthcare to what the patient wants. It's hard to believe that in 25 years' time, or perhaps ever, we will be able to use machines to do that. What the patient wants is based on their values, their beliefs, and the context of the day that they come to see you. Is their daughter getting married next month? Is their wife in a nursing home? And so on and so forth. How is that going to affect their decision making? So we as anaesthetists need to work in partnership with our patients to help them make decisions about healthcare. We are applied physiologists and we are communicators. And that puts us in a brilliant position to lead this march forward. So that is why I think that is the future of healthcare and why anaesthetists will be needed in 25 years. Thank you.